So next, moving on to the next session, we have the next speaker, Dr. Akhtar Hussani from Norway. He's a visionary leader. He has over the last 25 years of his professional life demonstrated his competence as a bridge marker across culture and national boundaries with committed leadership in academia as well as in diabetic care in poor Bangladesh, Pakistan, India, Sri Lanka, Nepal, China, Tanzania, and Zimbabwe, as well as in Norway, UK, Germany, USA. He has worked tirelessly to secure the voice of the people with diabetes through member association to the IDF and the world. And a skilled diplomat, his collaborative, context-specific, and solutions-oriented approach to the global health and international relations in diabetes care is respected worldwide. Currently, he is serving as the president of Diabetes Asia Study Group and the co-editor of the Journal of Diabetology. He has served in different programs of IDF since 2008 in the Bridges program as a reviewer and co-chair, and finally as vice president 2013 to 15 and 2016 to 17. He has experience to organize diabetes care both from the rich and poor countries. He is a life member of the Diabetic Association of Bangladesh and executive member of the Norwegian Medical Advisory Body for the Norwegian Diabetic Association. He is the founding member of the Diabetic Asian Study Group. He has been working with the Diabetic Association of Bangladesh, the proposer of the UN resolution on diabetes for the last 25 years in a resource-constrained society, while he has lived in Norway for the last 32 years, an affluent society in the academia and also in diabetes care. He has realized the differences in organizing diabetes care in different societies, but most importantly, how diabetes care can be organized successfully in poor settings. He has initiated collaboration for type 2 diabetes and type 2 diabetes research with Oslo, Norway, as a coordinator with 21 academic partners from Europe, Asia, and Africa. So he'll be speaking on today's topic, that controversies in prognosis, in diagnosis and management of GDM. Before his talk, we have a poll question. Kindly look into that. According to you, the best method of monitoring blood glucose level in GDM, is it SMBG, continuous glucose monitoring, is it HbA1c, or fructosamine? The poll is open now.
Thank you so much. And I'm just putting my, first of all, I would like to thank Dr. Bansi Sabu and Chatang Jashi and the organizer for inviting me. It's a big pleasure for me to be on this. I'm a regular guest at the Diabetes India conference, and this time I'm very happy to see that you have not forgotten me despite of this corona epidemic. So I'm very pleased to be here. And thank you so much for your kind introduction about me. I mean, this only tells that how old I am rather than what I have achieved. But anyway, so yes, I have been working in different, as you've said, the different parts of the world, and I'm working particularly on prevention and diagnosis of diabetes, GDM, etc. And yeah, so you have already said a lot about me, and so I would like to, if you ask me, is it that you want me to answer this question? Okay.
Question was like 33% in all the things. The poll result was 33%.
Yes.
So
yes.
Except HbA1c, the SMBG, continuous glucose monitoring, and fructosamine, all have got a 33%. Now you have a good task in plan to convince all of us about the controversies.
Okay, thank you so much. So I will get back to you. I can share my screen. First of all, I do not know that shared. I'll take this one. Okay.
Yeah.
I think I'll have to. So in my presentation, I'll be talking mostly that the gestational diabetes and its prevention. That I said that this is one of my interesting area, and in what is the importance for Southeast Asian, that I call the South Asian puzzle. And this is something that we are, some of the data that I'll be presenting from Bangladesh. As you might know, that I'm originally from Bangladesh. And so therefore I feel very much at home because I do not see the India and Bangladesh as two different countries. And so I feel very much at home when there is anything in India. So the next question is that I said that I don't have any financial disclosure. I have nothing to disclose, but having said it, as you might know, that now I'm the president-elect of the International Diabetes Federation. So International Diabetes Federation received some grant from some pharmaceutical companies to do studies on gestational diabetes, which has started actually before I joined the idea. So but personally, I do not have any project which is supported by any pharmaceutical companies. So we have to start with the saying that what is GDM? That we say that, for example, the WHO is now trying to say that glucose intolerance recognized for the first time during pregnancy brought by the insulin resistance or normal pregnancy and demand for the beta cells. And the problem is here, it didn't exclude women with the pre-existing diabetes. For example, we know that there is 50% people who remains undiagnosed. So therefore there is a risk that when we say that any kind of dysregulation in pregnancy will be termed as gestational diabetes. So with this word, so I will have to put the pre-gestational diabetes and gestational diabetes. There are two parts that I'm trying to do. That it can be the pre-gestational diabetes, both of type 1 and type 2, and the gestational diabetes which will be diagnosed during the pregnancy. If we look at the global magnitude, we see that there are differences. For example, as from the international publications, that what we see that this American, that the Caucasians, they're about 4%, and South Asians, the term as 8 to 9%, whereas the Europeans consider less than 4%, and Australian Caucasians, it's about 4 to 5%. So there is a difference, there is a mismatch. But when you see the local Indians, that I will show you, that they said that it's about 18%, and I will show that in Bangladesh it's actually similar, it's about 19%, but you say, and China and Japan is about at 3%. Why this variability in prevalence? Is it due to some genetic variabilities or responsible for different criteria for screening? And so we still don't know whether this is the diagnostic criteria or it's the biological variabilities that is causing these differences. So if you look at this, magnitude in India, that for example, Chennai hospital-based universal screening that they have done, and you see that it's about 18.9%, and then you also have different parts. For example, you see Trivandrum, Bangalore, Erode, and for at the same time in Chennai is much lower. And why this is difference in different parts of India, this is also quite interesting to look at. And as we know that the guidelines for the diagnosis in the Indian scenario, the DIPSI, we all are familiar. I do not have to spend time to discuss about the DIPSI system. I'm sure that our colleagues in India, they are well aware of it. But if you look at this diagnostic criteria for so then we have a number of diagnostic criteria. Sullivan is one of the, Carpenter, the strict WHO, and there was a modified WHO, and there's the HAPO. So these are all, and if you look at this, for example, the fasting to 1 hour to 2 hour, and what are the requirements, that whether you need the 1 hour and 2 hour, and whether it's only fasting is alone, it varies a lot. It's a question that which diagnostic criteria we are using. The biggest problem is that we do not have any kind of international agreement. And one of the things that we are more and more concerned that the international agreement does not necessarily represent the different population. And this is one of the major challenges in developing the international guidelines. As you know, that even though you go by one-step approach or by two-step approaches, you see that if you follow the two-step approaches of NDDG and the Carpenter, you see that the measures, for example, 1 hour, the 1 hour values to, for example, 1 hour values to 2 hour values, you see that all differs. So it's a question that which one you are applying and what its relevance in terms of prevention of prevention of complications related to the GDM. So that is one of the reasons that why we want to treat our GTM cases. So, and that you see that this is the NIH consensus paper is saying that the variability in 2-hour OGTT differing results in about 25% women in perform at different times in one-step testing may result more false positives. That was, they say, pooled meta-analysis of 5 randomized clinical trials is also resulted in birth weight differences of less than 150 grams. So you see that there's a whole lot of challenges. We are raising the questions, and for example, what is the, if we are thinking of macrosomia, then you should also think that obesity contributes most to the LGS, and what is then why we are treating GDM, and there are studies that showing that treating milder form of GDM may not benefit anything. And for example, adopting the ADA criteria, they says that it will projected is about in the US alone is about 100,000 more clinical visits, and there will be about 636 million to $2 billion extra costs. And the question is that whether this money spent is worth spent. If you look this Bangladesh, that we said that we have done this study in Bangladesh, and we see that it's we are coming to about 19.3%, which is more similar to the studies that we have seen in India. But if we put it at different criteria, for example, ADA, WHO, DIPSI, and so you see that IAD, PSG, so this has the highest number of prevalence, 19.4, which is could be with the DIPSI, it could be about 7.3%. So which one is right for us? Is it 19.4% that we should be treating, or is it 7.3% that we should be treating? What is the question? What is the what is the problem treating, for example, false positive cases? And this is one of not only a kind of clinical dilemma, it is also a kind of ethical dilemma we physicians do share. And then if you look at this, for example, the body size of this, you see that these are the two picture that you see. This is Indian women. This is one screening from India, the pregnant women, and the women in the Western world, the Caucasians. We see that then it's question that whether this kind of guideline for the gestational weight gain should it be similar. It's a question that, where, for example, we are saying that if you have a low BMI of 18.3, how much is a recommended gain, and BMI of the, so whether this is this universal guidelines, the problem is that whether it is addressing our issues. And then I'm showing that in Bangladesh, in this study, that what we have seen, that what they have gained, that actually in this lower group, they have gained only 9.6, which they should be actually gaining about 30. And in the, so nobody is gaining other than those overweight, for example, according to the Asian cutoff of BMI of more than 23. So they should be gaining about 6.8, and this is between 5.9. So probably they are gaining, they are achieving the targets because they're gaining, they should gain less. But the rest of the things, and I'm not presenting any data, we have looked at the children of this in terms of the birth weight, there is no difference. There is no, low birth weight is not associated with the weight gain during pregnancy. And there was, we have also looked at this, for example, insulin resistance and the cardiometabolic risk in the newborns, there is no difference. So that probably is saying that, for example, the weight gain that we should be thinking of, or we should be advising, is probably was not adjusted for the Indian Bangladeshi woman. And then if you are looking things, as I said, that if you're thinking of the preventing macrosomic children, and as you know, that a thrifty phenotype, that we know that this is poor nutrition, that in the beginning that people used to think of this poor nutrition and overnutrition, actually both will have an effect on gene expression. And then it will have an effect on this birth weight through the environmental stimuli, or the catch-up growth in the low undernourished mothers, leading to the metabolic syndrome. And this is giving an effect on the birth weight. So both poor nutrition and overnutrition will have an effect on birth weight. And then I see that how it affects us. You know, this work of Professor Yasnik from India, and then this the so-called the Indian thin fat baby versus the white Caucasians. He says that this is quite this is a reminder that our babies, even though they are smaller, but they have a kind of higher body fat percentages. And there is this study is from UK, and then they have looked at, for example, these white children with the UK-born Indians and foreign-born Indians. So you see that these are the white children compared to the UK-born Indians and foreign-born Indians, and it is also Pakistanis, and this is Bangladeshis. What we see that we have constantly lower birth weight. The Pakistanis, the Indians, the Bangladeshis, we have lower birth weight compared to this British original, the British natives or the Caucasians. But then these mothers are possibly not undernourished. So this is one of the dilemma that we need to think of. And gestational weight gain contributes more to the LGS and then for the GDM. Look at this, for example, the white population, the black population, the Hispanic population, and the Asian Pacific Islanders. The population attributable risk to LGS is quite remarkably that if you look at the GDM, that how much they contribute, excessive weight gain and BMI more than 25%. So if you look at this, for example, how much they are contributing compared to the GDM, is in all population, it seems that it is actually the BMI is contributing more than the GDM. And this is also the maternal obesity is more risk for childhood obesity than the GDM. This is also the study that it has shown that the correlation between the maternal obesity was more important in this regard. So looking at this, what are the risk factors for GDM? As we said, that BMI of more than 30, higher age at first pregnancy, higher fetal growth, previous macrosomic children, previous gestational diabetes, family history of diabetes, and certain ethnicity, for example, Asian, Caribbean, and Middle East. Then I'm going back again to my study in Bangladesh, that what we find the risk factors for this population. We see this, for example, that's the family history of diabetes, which is coming. The BMI is becoming overweight. Actually, it starts from more than not 30, is actually 23. So for our population, we must lower this BMI category. Waist circumferences, neck circumferences, and mid upper arm circumferences. These are the factors that we see that's related to the GDM. And then if you think of the laboratory parameters, for example, then we see this for the anemic mothers. Anemic mothers seems to be at risk. And as of course 2 hour blood glucose and A1C will be related to this, and cholesterol, LDL-C, and vitamin D. So these are the things that we are finding are relevant for our population. That my third question is that how we are managing GDM. In managing the GDM patients, it is an individualized medical approach, which is essential. But having said it, that we should have some kind of common guidelines. That is that if the maternal glucose levels have increased, insulin can be used to achieve glycemic targets. Traditionally, we have used insulin. But we are seeing that more and more sulfonylurea and metformin is coming in the treatment and they're saying that the adverse effect after that insulin or the risk of diabetes after in mothers GDM, that the mothers who are treated with insulin seems to be have higher risk compared to the mothers treated with metformin and sulfonylurea. So but these are the small studies. We need large scale studies to confirm these findings. There is no international agreement on the diagnosis guidelines for the management of GDM cases, as we have seen before. And the postpartum screening for diagnosis of diabetes is essential for women with previous GDM, and which is lacking particularly in our part. And then we are coming back to the pharmaceutical management that insulin has been used as a first choice for the last 30 years. And ADAs now recommends insulin treatment for GDM. As I said that, however, the use of oral hypoglycemic agents are increased in the last 10 to 20 years. Metformin, glucosamine, and these evaluate for insulin alternatives. In metformin treated studies that I said that evaluate equivalent pregnancy outcomes show such decreased weight gain and maternal hypoglycemic event. So these are the things that we need to look carefully. As I said, that these studies are still small, and probably these studies need to be done in a specific ethnic population so that we know that what is right for our population. However, there is no long-term clinical data in the offspring exposed to these medical treatments in order to ascertain the effect on the children. What are the questions that we should be asking that when we are taking the decision, that how can we select an odds ratio threshold in the absence of a true threshold in the data? That what are the false positive rates during using this threshold for the diagnosis of GDM? And what is the impact of the patients and workload for increasing the prevalence of GDM, and what is its benefits? Do you have sufficient evidence with respect to treatment benefit in the various thresholds to make an informed decision? In the absence of clear benefit, should we diagnostic criteria be changed from 2008? And controversies about the gestation diabetes, as I have said, that there is debate about several aspects of GDM, including the diagnosis, including the number of grams of in the glucose to administer, controversies in GDM testing, including one-step versus two-step testing, Carpenter, and other diagnostic criteria, number of times to be measured blood glucose in the OGTT specific threshold for diagnosis, and number of measurements needed to determine abnormalities. There are also disagreement about the screening approaches, whether the screen should be selective or universal. That people are whether we should go for universal, because universal treatment will definitely cause a lot of expense, particularly in a resource constrained society like Bangladesh. And India is affluent, but given the size of the population, this is the affluence is not yet there. So we should think critically about this, and the discrepancies even exist over how to label the condition of pregnancy assessed during hypoglycemia. Disagreement also exists for the treatment approaches. So therefore these are the controversies that we do not have. And I think that today, in this, given the kind of knowledge that we are coming from different ethnic population, and I think that it will be very difficult. IDF is now working on this issue, and during my time, I think I will try to focus on my women's health and diabetes, which Shaukat Sadiqat was also thinking a lot about it. And so we will try to focus on it, but I think that we'll have to go more and more, this is my personal view, on ethnic-based guidelines rather than a kind of international guidelines. And international consensus has not been reached for screening diagnosis in which clinical laboratory testing plays a critical role. New regional and international data are required to reach an agreement with possible differences by ethnic-based guidelines, as I have said. Ethnic-based guidelines would be interesting. You have seen that I haven't gone into that they have done one Cuban guidelines, which differ in some ways for GDM, but satisfactory results are getting from national rates similar to those elsewhere in the Americans for preeclampsia, which is 5%, preterm delivery around 12%, congenital abnormalities about 4.3%, and parental death is about 4.8%. So these are not very different compared to the others. So question is that why we'll be following the other Cubans are trying to make it so, and therefore I think that a resourceful country like India, not only in terms of money but in terms of knowledge as well, I think should take the lead for future works. Thus, Cuban criteria differ, but there is no evidence that other guidelines could do better for the Cubans. And this is something that we need to think of. So I'm not giving any answer. I'm raising a number of issues which are controversies, and I'm asking, including my country, Bangladesh, and also India, Pakistan, and wherever I travel. I have also a kind of a guest professorship in Brazil. So I'm asking everyone that whether we can come back, we can do the studies and we can look at it, and maybe it is time for us to say that we need to develop ethnic-based guidelines. Having said it, ethnicity is a kind of social term, it's not a kind of medical term or a biological term, and that also brings up a number of challenges. If you look at this last slide, this is the committee opinion, the American College of Obstetricians and Gynecologists. So they said there is no evidence that the identification and treatment of women based on the new International Association of Diabetes in Pregnancy Study Group, which we have shown that there is heightened, there is about from 19% to 7% there in terms of prevalence of GDM in Bangladesh. This will lead to a clinically significant improvements in maternal and neonatal outcomes. So we do not have any evidence. And it would lead to significant increase in healthcare costs. So this is something that we need to think about for our actions as physicians, and not only the physicians, we also have a responsibility as citizens of a country. Thank you very much for your time and for your attention.
Thank you so much, Dr. Akhtar, for the wonderful presentation. I think we'll take the questions at the end, so we can move on